Hydration and IV Therapy, Part 6, Iowa Lakes Community College, Introduction to Nursing Concepts. This is Martha Olson. As we look at page 883 in the Potter and Perry, osmolarity is the pressure of a solution. It's expressed in osmoles or milliosmoles per kilogram of solution. It kind of describes what we call the tonicity of infusions that are administered IV. When we look at osmolality, then, that's the number of particles per kilogram of water. When we look at table 41.1, it talks about 280 to 300 milliosmoles per kilogram of water, normal values in blood or serum. So when we look at osmolality, then, that's kind of the pull or pressure that exert by the particles in the water. And it's influenced by the quantity or the number of dissolved particles. So, if you have more people in a room, it's going to push them out the door or encourage them to go somewhere else. When we look at our infusion classification, then on page 904, the crystalloids or electrolyte therapy, they have the capability of crystallization or to form crystals. And when we put them in a solvent, then they mix and they dissolve evenly, so that you really can't distinguish a crystalloid from, the original solution that it had. They can diffuse through membranes, and they're usually electrolyte solutions such as isotonic, hypotonic, or hypertonic, the ones that we were talking about in class the other day. And then our colloids are just the opposite of the crystalloids. When they're submerged in a solvent, then they don't dissolve. They remain suspended uniformly and distributed throughout the fluid. What they do is they raise the colloid osmotic pressure. They are your plasma or volume expanders such as albumin, dextran, plasminate, hetastarch, or artificial blood substitute. So our colloids, then, blood contains albumin and other proteins. They're fairly large. They're larger than our electrolytes, glucose, and other molecules that dissolve easily. Page 885 is where they are talked about. So 883 in Potter and Perry gives us then our IV fluid classifications that we have. Our isotonic, as I mentioned in class, is your saline. Our danger for isotonic is fluid overload. It might decrease or dilute out the hemoglobin and make it look and be in a smaller amount because you have too much volume. When we look at isotonic, remember they have that osmotic pressure that's equal to the osmotic pressure of the intracellular and extracellular body fluids. So they just expand the volume. They don't exert any push or pull. They just cause you to have more volume. They don't cause any shifts. Normal saline, 5% dextrose in water is the one that is isotonic. It falls off my rule of dextrose being a hypertonic, but your 5% dextrose is considered an isotonic, as well as lactated ringers. Our hypertonic then is a solution that has osmotic pressure that's higher than the osmotic pressure inside the cell, or intracellular and extracellular. They raise the osmotic pressure, and the fluid then will shift from the cell into the extracellular compartment in an attempt to decrease the higher osmotic pressure. Our fluids that are hypertonic tend to have dextrose in them. D5.5 normal saline, 5% dextrose in normal saline, 3% saline and 10% dextrose are hypertonic. And then hypotonic is the one that has a lower osmotic pressure than the intracellular. They provide more water than electrolytes. They dilute, and they cause the fluid then to shift from the extracellular to the intracellular fluids. Our 9% saline that's less than 9% strength, such as 0.45 or 0.225%, are considered hypotonic. So when we look at our isotonic, they don't affect the cell size. They expand. They're listed here for you. Our hypotonic shifts, again, the fluid into the cells. And our problem with that is the cells can swell, and if we aren't careful with hypotonic, we can cause the cells to actually be damaged because they take in too much water. Our hypotonic are listed there. Our half-strength saline, 0.33. Our hypertonic causes cells then to shrink. Our examples are usually with dextrose. They require frequent monitoring of blood pressure, lung sound, sodium levels, because we worry about fluid overload, water from the inside of the cell to that extracellular compartment where our salt content is higher. We use our hypertonic for things like hyponatremia, shock. It helps temporarily treat some circulatory insufficiencies, and we have to use them very carefully with patients that have congestive heart failure, pulmonary edema. Give them slowly because we can cause overload. Our dextrose solutions give the advantage of giving some calories, some nutrition. They help treat hyperkalemia. They help treat dehydration. They give some free water. But our dextrose solutions also can be irritating to the vein, and we have to be careful with that. Causes hemolysis of blood cells, so we can't use these when we give a blood transfusion. Dextrose would damage the blood or cause hemolysis of those cells, and so we would want to be careful that we are only using normal saline for a blood transfusion. Always, as a nurse, in consideration your intake and output, monitor your potassium levels, and this dextrose then is considered a crystalloid solution. Our sodium chloride, the advantage is that it expands extracellular fluid. We use this with the blood transfusion. We can use these with fluid challenges because it doesn't cause a lot of problems. The disadvantage is you can cause circulatory overload, so we would always watch our vitals, look for an abounding pulse, increased pulse, higher blood pressure. Listen to the lungs, worry about circulatory overload. Are they short of breath? Are the O2 sats falling? Next on the list is looking at our plasma expanders such as dextran and mannitol. Our colloid solutions contain protein or starch molecules. They remain distributed in that extracellular space. They increase your fluid volume. They're used with large fluid losses, severe trauma, hemorrhage. You'll see these used to help expand the blood, and it's because they're larger protein molecules. They're able to do that. They can remain in the vascular space for several days. They draw fluid, increase that intravascular volume, and so we think of these in the ER, in the ICU, primarily being given for our trauma patients or those with hemorrhage or sepsis. With our plasma expanders, the disadvantage is you can have an anaphylactic reaction because it's a protein. And our anaphylactic, remember, is your wheezing, itching, or urticaria, nausea, vomiting, or hemorrhage. Our hetastarch is the next one, where it increases granulocyte yield during leukapheresis. And with albumin then, it increases the plasma volume post-intravascular loss, and we use albumin as a plasma volume expander for shock or impending shock related to circulatory volume deficit because it pulls the fluid where it needs to. We infuse these within 4 hours. It provides our volume expansion. We also want to consider a blood product. And so with these considered a blood product, you know, we have to watch for allergies and reaction, but we do not have to cross-match when we use these products, these plasma expanders. Albumin is a protein. Remember, it's made in the liver and helps maintain that osmotic pressure that causes then the fluid to remain where it should in the bloodstream. The albumin levels become low. With those that have a poor diet, your alcoholic with liver disease, anybody with kidney disease, or overexcretion of some of our protein products. So when these levels become low, then the fluids leak into the tissues. What we see is your patient with a lot of peripheral edema, pulmonary edema, ascites, other evidence that they're third spacing, or it's not in the intravascular, helping maintain the blood volume, but it's in that third space or that interstitial space where it just kind of sits there causing edema and problems with getting it back into the circulation. Our multiple electrolyte fluids then are ringers, LR or lactated ringers. These are used to treat dehydration. They restore fluid balance before and after surgery. They contain sodium chloride and a little bit of potassium, calcium, and lactate. And so with these electrolyte fluids, we have to watch our electrolytes very carefully and make sure that they have good urine output. There's no calories provided because there's no sugar or dextrose in them, and they can exacerbate some of our sodium retention. So your patient with congestive heart failure or renal insufficiency may not be the best option for them. These are fairly well tolerated in people with liver disease. And last on our list for this portion of our slide is our potassium chloride solutions that are added to the IV. Remember, we never give potassium IV push because it could kill a person. We replace potassium generally very slowly. Watch the heart, watch for dysrhythmias. When we think about our potassium, we want to make sure it's diluted. We invert and agitate the fluid bag after it's mixed. Most of the potassium that is mixed in a fairly common IV solution is a premix, and so you go to the Pyxis, you put in that you want D5LR with 20 of KCl, and it's already mixed and ready for us. Again, watch your EKG, watch your tele with these. Watch your potassium level and make sure you have good urine output, because if you get hyperkalemic on the other end of the spectrum, that can be problematic as well. With IV potassium, remember it's irritating to that IV site, so try to use a bigger vessel, a larger gauge IV if you can, and then if it's burning, sometimes it is helpful to slow the rate down and the patient is better able to tolerate that. So as a recap for this part 6, we think about the different IV types that we have. We have osmolarity and osmolality as two factors that help us to know the pressure of the solution and the particles in the solution. Then we take our crystalloids and break them down into 3 different types of solutions: our isotonic, hypotonic, and hypertonic. They each have an advantage, they each have a disadvantage, and they're used and ordered by the physician. As nurses, our big thing is to watch for IV site, fluid overload, is this the correct rate and type of solution for the patient that we have. And then we've finished up talking about some of our plasma expanders that are considered a blood product, but unlike the blood products, we do not have to do a lot of cross-matching with them. Our head of starch and albumin are given for people that are in shock, trauma, high-risk patients would be getting those plasma expanders to help maintain their volume and get them kind of back on their feet. So this ends part 6, and we will finish up. We have 2 more units to go, and we will be done. Thank you.